Hey guys, this is Pete. I wanted to talk this week about soft tissue ultrasound. As with many bedside ultrasound applications, we have a few pointed questions when we walk up to the machine and the patient in the emergency department. The same is true for soft tissue ultrasound, which is an application that even a novice sonographer, community sonographer, or someone with not a ton of training can learn and implement pretty easily into their practice and make some significant strides with patient care. The big questions are: is there a cellulitis underlying your patient's malady? Is there an underlying abscess that needs drainage? As well as procedural guidance. So, using soft tissue ultrasound to help drain an abscess to determine if the abscess is completely drained, and also to assist with foreign body removal as well as identification of foreign bodies. So, first off, number one is you probably have heard of cobblestoning and associated this reflexively to cellulitis. Just want to take this out of your um, knowledge base and say that yes, it can be cellulitis, but it also can be a few other things, such as simple edema, dependent edema, vascular edema, as well as swelling associated from anaphylaxis or an allergic reaction. So that needs to be in your differential. If you haven't heard of cobblestoning, these are cobblestones, one. And this is what they look like with an ultrasound. So as you can see in the top of your screen here, the soft tissue is surrogated and appears as if these white, bright hyperechoic areas are surrounded by these darker anechoic structures. This, as I mentioned before, signifies edema or swelling. Here's another example right here. This is pretty apparent and unmistakable. The other thing I want you guys to appreciate is that we have a depth of 2.5. So whenever you're doing any soft tissue ultrasound, use these calipers on the side to help you determine how deep your point of interest is. And lastly, here's another example of cobblestoning. Each of these is from a actually different entity. So one was from an cellulitis, one was from simply lower extremity edema, and the last one was from a swelling or anaphylaxis. Next, go on to abscess. So first off, when we think of an abscess, we think of a fluid collection that's dark, correct? So an anechoic fluid collection. Part of this quick talk will be kind of to take you away from that and to broaden your idea of what an abscess can be. But the simple abscess that we see all the time looks like this. As you notice, the posterior aspect of the abscess is very bright. So this is called posterior acoustic enhancement. You'll see this in the bladder. You'll see this in the gallbladder. You'll see it when you scan an eyeball. Look for this to help you decide whether you have an abscess under the skin. As you notice on the left and the right of the screen, you don't have that brightness. So you know that the ultrasound beams are moving very quickly through this fluid-filled structure, thus causing this very bright hyperechoic texture to the bottom of the screen. Again, use your functionalities of the ultrasound to help you determine how large an abscess is. Here, it's about a centimeter and a third deep, as well as about 2 centimeters wide. And you can use the calipers on the side as well to help you determine. Again, notice the brightness here on the posterior aspect. This was actually an abscess on the chest wall, so the other additional benefit of using this or doing this exam was to determine how far the pleura is away from the surface. So you're not going to, when you do drain this, you're not near the pleura, you're not going to be at any risk to cause a pneumothorax. Here is 4 centimeters down, and remember the abscess was only about 1.33 centimeters, so you have plenty of space to maneuver. What about MRSA infections? I mentioned that not all abscesses are beautifully anechoic and circular and easy to identify. This is something that I picked up in fellowship, and it's certainly not widely taught, but it's becoming more and more apparent that MRSA abscesses tend to have a different appearance on ultrasound. As you can see here, This is called the squish test, or there's actually pressure being applied to the probe. You can see that as it bounces up and down. But at first glance, if you were to pause this image, it's not going to look like that abscess before, which is nice and circular. As you can see here, there is fluid and abscess and purulent material stuck in this cavity. And you can see that it actually tracks down pretty far, so 2.5 centimeters here, probably almost about 2 centimeters down. You'll also notice how the texture of the ultrasound image is a lot brighter down here. Again, this is this idea of ultrasound imaging, or waves passing quicker through a fluid medium. Here's another example of a complex abscess. MRSA abscesses tend to be more jagged, less circular and smooth than simple abscesses in the ED. Again, tough to determine right at this onset, right at the beginning. It doesn't look like much, but as you move around your probe and as you apply some pressure, you're going to see some movement of material, of purulence in this area. So whereas someone you wouldn't necessarily drain initially, make sure that you do these small, subtle movements, such as putting pressure and scanning through the entire object that you're worried about to see if there's some movement of fluid. And I think overall we're probably doing a little less incision and drainage than we ought to be. I know that I was before the last couple of years. Again, at first glance, doesn't look like much, but as you move the probe, you can see this movement of material. So this is an abscess pretty deep here. Again, it doesn't have the calipers on the right here. It's probably somewhere around 4 to 5 centimeters, so this is about 2 centimeters down. Here is where you'll see some movement of fluid, so you probably could get some satisfying drainage from incising this wound as well. And as you can see, it's very bright down here, suggesting there might be some fluid medium passing through. What about necrotizing fasciitis? Just quickly on this. They did a couple studies recently, one done at UMass, talk about subcutaneous tissue swelling and fascial plane thickening to be determinants of necrotizing fasciitis. I think for the novice learner, basic learner, the key things to look for is just gas. So necrotizing fasciitis or necrotizing infection makes gas in tissues. Gas does not like ultrasound, or ultrasound does not like gas. So just with the lungs, when you scan the lungs to look for sliding, you see a lot of whiteness below the pleural line because the beams aren't passing through the air. Same with ultrasound and necrotizing fasciitis. If you look here on the left side of your screen, there's areas of the soft tissue which immediately turn white and go all the way into the bottom of the screen here. That suggests that there's some air in the tissue, probably up around ½ centimeter deep right here. This is another image showing some occasional spots where there's gas in the soft tissue as well. Again, notice these areas, hyperechoic, bright areas with nothing being transmitted behind it, suggestive of possibly a necrotizing infection. Just some subtle things to look for when you're doing these exams, some things that can add to your clinical suspicion. What do you guys think this is? It's only about 2 centimeters deep. If I told you that this patient had a groin infection, what do you think of a particular entity? Yeah, so this is probably a Fournier's gangrene, or it is a Fournier's gangrene. These are testicles. These are swelling around the testicles. I don't see any significant gas formations, but I do see very thickened subcutaneous tissue, as well as fascial planes that appear thickened. And then lastly, this was a case I had last year of a nail in someone's thigh. Here's the nail here. It's just bright white. Long. It's a roofer, I think. So a roofing nail is pretty long. And it's bright white here. It assisted me with taking this nail out. I just used ultrasound. The reason I did is because the artery is right here. So as you can see, he missed a potentially leg-threatening injury by 0.3 centimeters. So this is a nail here. It's passing through this way, and this is the superficial aspect of the artery. So just to end on a couple tricks. If you're ever confused or want some more information, just scan the adjacent normal tissue, or if you're looking at an arm, look at the opposite arm at the same spot and compare your soft tissue findings. Remember that cobblestoning is not always cellulitis. It can be just edema as well as anaphylaxis or allergic reaction. Remember to apply pressure to help you with your abscesses, especially MRSA abscesses. And remember to apply color when doing this because, as you can see, significant vascular structures can be quite closely associated with your target, whether it be a foreign body or drainage of an abscess. So that's it for now, and we'll talk to you again soon.